Picture this. You're in an intensive care unit. It's controlled chaos, right? You've got alarms blaring, numbers flashing everywhere, and someone's life is literally hanging in the balance. Now, in those moments, the pros, the experienced clinicians, they don't panic. They have this powerful mental model, a master algorithm that helps them cut right through all that noise. And today, we're going to break that exact algorithm down piece by piece. Okay, so let me just ask you straight up. In the middle of an ICU crisis, when everything is going wrong, what's the very first thing a doctor does? What do you think? Do they run for the defibrillator? Stare at the heart rate monitor? Check the oxygen levels? What's that initial move? Well, the answer, it's probably not what you think. It's not about all the fancy technology. It's not about the data streaming across the screens or some complex piece of machinery. Nope, it's something way, way more fundamental. Okay, let's get into it. It all starts with something we can call the 10-second rule. And this, right here, is the first and maybe the most crucial step to seeing clearly through all that chaos. Yeah, you heard that right. The very first move is to deliberately ignore that whole symphony of beeping monitors and just look at the patient. Look at the human being in the bed. I know, in our world that's obsessed with data, that sounds totally backwards, right? But that one simple action is the bedrock for everything else they're about to do. Because, the monitors, they tell a story, but the patient tells the truth. And in those first few seconds, they're not trying to diagnose some complex rare disease, no way. They are answering 4 just brutally simple questions. 1, is air getting in? 2, is the chest moving up and down? 3, is there a pulse? And 4, is the patient conscious at all? If the answer to any of those is a no, they act immediately, long before they have any idea why it's happening. And that right there is the core philosophy of emergency medicine in a nutshell. You just don't have time to figure out a detailed diagnosis when a person is actively dying. The number one priority is to stabilize, to intervene, to fix the life-threatening thing that's happening right this second. The why can wait. All right, so let's see how this whole principle works in practice. We'll look at the first 2 big life-threatening crises, a blocked airway and a patient who's in shock. An airway emergency is, well, it's terrifyingly fast, but the warning signs are unmistakable if you're looking at the patient. You might hear stridor. That's this high-pitched, awful sound of air fighting to get through a blocked airway. Or gurgling sounds, which tells you there's fluid where it shouldn't be. And then there's consciousness. If a patient is deeply unconscious, what doctors call a Glasgow Coma Scale or GCS of 8 or less, it means they physically can't protect their own airway. Believe me, these aren't whispers, they're blaring sirens. And the response is this rapid-fire algorithm. First thing, you never ever try to handle this alone. You call for help loud and clear. Then you immediately start breathing for the patient with what's called a bag valve mask. And while you're doing that, the rest of the team is already getting everything ready to intubate, to put a secure breathing tube in. It's like this synchronized, perfectly choreographed, life-saving dance. And here is the absolute golden rule on this. If you wait until the patient's heart stops from a lack of oxygen, you are already way, way behind the curve. Being proactive, even aggressive, about securing an airway that's failing, that is what stops a bad situation from turning into a total catastrophe. Okay, on to the second major crisis, shock. Now, this is where there's one number on that monitor you do need to pay attention to right away. It's the MAP, which stands for mean arterial pressure. Just think of it as the average pressure that's pushing blood and oxygen to all the vital organs. And when that number drops below 65, that's a huge red flag. It means the organs aren't getting the fuel they need to survive. So the response here is all about speed. First, you hit them with a big bag of IV fluids. We call it a fluid bolus to kind of fill up the tank. But here's the really crucial part. You start a drug called norepinephrine early. It's a vasopressor, which just means it squeezes the blood vessels to get that pressure back up fast. And we know from studies that doing this early saves lives. And only after you've done all that, after you've stabilized the pressure, do you start playing detective to figure out what caused the shock in the first place. All right, let's move on to the events where the clock isn't just ticking, it's practically screaming at you. We're talking about cardiac arrest and when a patient who's on a ventilator suddenly crashes. When it comes to cardiac arrest, there is zero time to waste. Absolutely none. These actions have to happen with no delay. The second you know there's no pulse,
Someone's hands are on the chest, starting good, hard compressions. At the exact same time someone else is putting the defibrillator pads on, if it's a shockable rhythm, you shock. Then you give epinephrine. That sequence, it's automatic, it's non-negotiable. And look, if you remember nothing else about cardiac arrest, please remember this. The single most important thing that predicts someone will survive, it's not the drugs. It's not even the fancy breathing tube. It is the simple, physical act of starting chest compressions right away. That's it. That's what keeps blood moving to the brain. Okay, now let's switch gears to a different kind of crisis. Imagine this. A patient's on a ventilator, seems totally stable, and then all of a sudden their oxygen levels just tank. It's the kind of thing that can make anyone panic. But there's this amazing little mnemonic that stops the panic and gives you a crystal clear checklist. All you have to do is remember the word DOPE. DOPE is just a brilliant troubleshooting guide. D is for displacement. Is the breathing tube still where it's supposed to be? O is for obstruction. Is the tube blocked by something, like a mucus plug? P is for pneumothorax. You gotta wonder, could the patient have a collapsed lung? And finally, E is for equipment failure. Hey, maybe it's not the patient at all. Maybe the ventilator itself is broken. It's a checklist that instantly turns that chaos into a calm, step-by-step search. So we've looked at all these different emergencies, right? Airway, shock, cardiac arrest. But how does it all tie together? Well, now we get to the master mnemonic, the one single framework that pulls all of these different algorithms together into one beautiful, simple sequence. But before I show you, let's just hammer home that core idea one more time. Think about it as two different stories being told. The monitor is telling one story, MAP is less than 65, oxygen is low, alarms are going crazy, but the patient is telling the real story. They're gurgling, they have no pulse, they're unconscious. Now, which of those two stories needs your attention right now? It's a no-brainer, right? You treat the human, not the screen. And so here it is, the master memory hook. This little thing works for something like 90% of all ICU crashes. It's just A, B, C, P, D. A is for airway. First things first. B is for breathing. C is for circulation. You check for a pulse. Then P. P is for pressors, those drugs for shock, or for CPR if the heart has stopped. And only after you've gone through all of that do you get to D for diagnose. See? It's just a perfectly logical, simple cascade. Which brings us right back to where we started, to the final and honestly the most important lesson of all, the golden ICU rule. Check the patient, not the monitor. It's that simple. Most of the really bad outcomes in critical care happen when smart, well-meaning people get hypnotized by the numbers on the screen, and they forget to just look at, listen to, and touch the actual person in the bed. Because at the end of the day, the most advanced piece of technology in that entire room is still a trained human's eyes and ears. And that really just leaves us with one final thought, doesn't it? In a world that's becoming more and more about big data, AI, and incredible technology, is it possible that the most vital sign of all, the one that really, truly tells us what's going on, is still just human?